Good afternoon or evening to you, depending on where you are in the country. I'm Alicia Rowell. I'm AIM's Vice President, and I want to welcome you to this webinar called Tissue is the Issue. We'll tell you a little bit about the Melanoma Tissue Bank Consortium, how it works, and what it will do for patients. I'm here with Dr. Mohammed Kashani-Sabet, who is the Director of the Center for Melanoma Research and Treatment and Medical Director of the Cancer Center at California Pacific Medical Center. Welcome, Dr. Kashani.
Thank you. Thank you for having me.
We've only got about 30 minutes, so we're going to jump right in. And to all of our listeners out there, I'll be able to review questions as we go. If you're on Zoom, you can put them in the Q&A. If you're on Facebook or YouTube or one of the other ways to watch, you can put them in the comments section. But more than likely, I'll leave them to the end to make sure that we don't already answer those questions in the questions that we have prepared. And if we don't get to your question, you can look in the chat right now, and my email is in there. And you can ask your question by emailing it to me after the webinar, and I or Dr. Kashani will answer you. So to start this out, Dr. Kashani, would you tell us a little bit about your medical specialties and your research?
Sure. So I'm a dermatologist in San Francisco at the California Pacific Medical Center, and I also did cross-training in medical oncology. So I'm trained in both of those specialties, although I'm a board-certified dermatologist. So that's really my primary area of specialty, and my focus is really patients with melanoma, all stages of melanoma, as well as patients who might be at high risk for developing melanoma. And then in terms of my research, the research that we do several sort of layers of research. There's clinical research, there's clinical trials, but primarily my own laboratory-based research is really focused on understanding the molecular underpinnings of melanoma progression. What is it that makes melanoma behave, less aggressively, in some people and more aggressively in others.
Okay, great. I know there is a lot to ask you about your research, and that will be interesting to our listeners and relate to the tissue bank. We'll come back to that later in the webinar. Since this webinar is about AIM's tissue bank, let's start with some basic information about tissue banks in general. The name of the project is the Melanoma Tissue Bank Consortium, and we refer to it as IMTBC. We also have two soon-to-be added branches in Australia, so you'll also see us refer to it as the International Melanoma Tissue Bank Consortium, or IMTBC. So getting a little more specific, the word consortium refers to the fact that 4 U.S. research institutions are involved. Which ones are those?
So they are Oregon Health Sciences University, or OHSU, as we refer to it in Portland, Oregon, University of Pittsburgh Medical Center, or UPMC, obviously in Pittsburgh, University of Northwestern in Chicago, and then us, CPMC in San Francisco.
Fantastic. And they share, all of you share data and tissue, which I guess also makes it a consortium, which you do together. And I like to think of it this way. The word bank refers to the fact that we're pushing tissue away for use later, just like people do with money in a bank. So we tend to call each of these sites a branch, just like we do with the banking metaphor. Are these branches physical structures? Do you have a physical building there at CPMC that is the tissue bank?
So I think the tissue bank itself is virtual, in the sense that we're all participating institutions, in the tissue bank and in the consortium, but each of us have, physical laboratories, physical space that's dedicated to research. And again, these groups were identified and recruited because we were already doing tissue collections. So we already had an existing infrastructure to be able to, put together these collections, for the AIM tissue bank. So we use the existing space and facilities that are in place at the 4 different institutions to create this virtual tissue bank.
Okay, great. That's a helpful explanation. And maybe I should add about the founder of AIM at Melanoma, our late founder. Her name was Valerie Guild. and her then 26-year-old daughter was lost to melanoma. This was in 2003. And Val was determined to improve the dismal survival rate. And as you know, she came to you with her daughter, Charlie. And she went around the world after she lost Charlie to ask experts what was needed. And I know you gave her this answer, and a lot of other people gave her this answer, was that we needed fresh frozen primary tissue, and we needed to collaborate on research. Those two things were severely lacking. So that's what she set out to do. And it took over 15 years, but IMTBC is open, collecting tissue in all 4 sites in the US. And our last reporting was the end of the third quarter of 2022. So at the end of September, that would be. And we are at 110 tissues as of that time, and still haven't added in the fourth quarter or January here yet. So that is fantastic. And we're continuing to ramp up. And you've had some struggles, I would say, all of you, with COVID. Tell us a little bit about how that's been difficult with tissue collection.
Well, I think, COVID impacted us in a multitude of ways, really, when you think about it. The first issue was, patients were not being screened. Early on when we had lockdowns in various, states and counties, the dermatologist offices obviously were not open. So the patients could not go and get their usual skin screening and get diagnosed. So, the diagnosis of many cancers, it's been reported, but certainly melanoma included in that, plummeted, during COVID. So the number of patients, even though we as a sort of referral institution, as a tertiary care facility, we were open really during the entire time, but sort of the number of patients coming to us was significantly lower during that. So from that standpoint, the number of tissues that could be collected were severely impacted because we're seeing less patients with, newly diagnosed melanoma or lesions or, spots that would be suspicious for melanoma that we would want to collect in this bank. So that was sort of number one. Number two, some of our research staff, the whole concept of, doing things virtually versus in person. So, the research staff, if they were not deemed to be, quote, essential, unquote, in those early days, they were not able to interact with patients, in the same way possible. So that also impacted things, in terms of, getting not just the tissue, but also a critical part of the tissue bank is actually the data, and some of that, we have questionnaires from patients and things of that sort. So that we try to get interactively, although there are web-based ways that this can be done as well. So that impacted as well. Yeah. So not just the patient population, but also just the staffing that we could have to support this project was also impacted.
Well, we hope everyone's ramping up now that we're really coming out of COVID, hopefully, knock on wood. Okay, moving to a typical tissue collection. Would you explain for our audience how a typical tissue is collected? What kind of patient comes in to see you and whose tissue is collected?
Yeah, so I think generally to really think about it, there are 2 pathways, where the patients could potentially be enrolled, in this kind of a study and in the tissue in the consortium. So the first one is a patient who's been diagnosed with a melanoma already, by a different practitioner, usually a dermatologist, but there's a partial biopsy. So this is a much bigger spot that was left, and they're referred to us for us to, take care of that patient subsequently with surgery and potentially other treatments. And so we already know that it's a melanoma, but there's tissue left that's not really required, for the patient's, care at that point. We already know that what it is, the diagnosis, and also how thick or deep it is. So we've already staged the patient. And so what's left can be easily, and safely collected for research purposes. So that's one pathway. And then the second one is a patient where we're seeing either existing patients or a new patient coming in with a spot that either they're concerned about or we're concerned about. And we're going to biopsy that, and we're not sure what it is, but it certainly looks irregular enough, both to the patient and to us, that it's worth biopsying. And again, if, we have size criteria to make sure that, it can't be too small, and you want to have adequate representation for the pathology. But in that scenario, also, once the patient is consented and they agreed in both of these scenarios to participate in the study, then at the time of the biopsy or surgery, that tissue could be collected and really frozen. We want to preserve that immediately at that time, either from the clinic arena or in the operating room.
Okay, great. I have a question from the audience, and I'm going to actually throw in right here. We often refer to melanoma as the most common kind, which is cutaneous. And if someone has a mucosal melanoma who comes to see you, is that valid for the tissue bank?
Yes, that would also be very, very valid. I mean, these are obviously rarer subtypes of melanoma, but even more the reason, to really collect these where safe, where possible, where accessible, to be able to do that. So this would be really valuable additions and components of this tissue bank. Absolutely.
Fantastic. Okay, so once the tissue is removed and your patient's walking out the door and you've got this piece of tissue there, where does it go? Help us understand.
So basically, let's say we're in the operating room and there's literally a runner there, to collect the tissue from the surgeon, the pathologist, from the OR, and then it's basically run to the laboratory, and we really aim to sort of catalog it and freeze it, within like half an hour, because that's the point at which if you let it sit in room temperature, beyond that, it can start to degrade, and some of the components that we're very interested in studying, principally, RNA, this starts to degrade, and so that information can become less reliable. So it's frozen, and then that's how it's preserved. And then, then the important thing now is the data. We have to now annotate that tissue. In and of itself is useful only to a certain extent, and it's really most useful when you couple the tissue and annotate it with the data that's really critical regarding the patient, but also that specimen itself. If it's a melanoma, what type, what are the characteristics, and then ultimately also the outcome data for that particular patient, because we'll want to know, 2 years, 5 years later, how is that patient doing, what happened, so that also is a critical component of the whole thing. In addition, we also have an arm that is very interested in susceptibility to melanoma. So we also have a epidemiologic questionnaire that participants are asked to complete, because we also want to know what happened to them earlier, if there's family history, how much sun exposure they had, et cetera, so that the known risk factors as well as potentially unearth novel risk factors, for melanoma. So we can also compare that and compile that information and really collate that with, sort of the molecular information that we're going to be getting out of the tissues.
Fantastic. I'm going to come back to that epi survey in a second. So specifically, it's because sometimes patients are amazed at this. When that tissue is taken away, it's stored in a freezer. How cold is it? Give us an idea of. I mean, you don't have to give us the exact number if you don't want, but how cold are we talking frozen?
Well, it's minus 80 degrees, Celsius. So it's very cold. None of us would survive that for very long.
All right. So tell us why fresh frozen tissue is so important. So maybe you'll have to explain how traditionally tissue was stored, and then this idea of it being frozen immediately at this very cold temperature. Why is that important for research?
Yeah, so, historically, when a biopsy is done, it's put in a little tube that has a fixative called formalin. And so, that is how tissue is stored, because it is very good. It's a very good preservative for routine sort of histological assessment, what the pathologist needs to do. And then that tissue is then from the formalin, when it goes to the pathology department, they dry it up and they embed it in a plastic cassette, basically. And it's basically covered with wax, which is a paraffin. So the classical way that the tissue is preserved is what we call, formalin fixed paraffin embedded tissue, or what we call FFPE in the vernacular. And that's very good for routine analyses. That's also very good for DNA, but that kills it for some of the other types of analyses, that are available, principally, RNA, because again, RNA can become degraded and RNA can be very heat sensitive, as we just talked about, but it can also be sensitive to these other kinds of techniques. And so really, what's really critical about having fresh tissue is the ability to preserve the tissue, especially for RNA and potentially also certain protein types of things that we want to look at down the line. And this enables us to do that we know. And so there are analyses that we've really been precluded from conducting because of the lack of this particular type of tissue.
Okay, great. You've touched on RNA. Can you give us an idea of why RNA is so important to research, or your research even?
Yeah, absolutely. I think that, so, when we think about the paradigm of, how essentially life forms develop, and we have the dogma of DNA, being transcribed into RNA and then being translated into protein. And certainly protein is the building blocks, those are the things that, make us who we are. Ultimately, proteins do everything. But, and DNA is what we inherit, and that's also important. But, when you can only look at DNA, you can only look at the mutation levels, So if there's a mutation in a particular gene, DNA will tell you that. But, what RNA is really the genes that are expressed, in a particular tissue. So what's really important about RNA is you can really actually understand, and we have, 40,000 genes, in each of our tissues, and, they're not all expressed, in each tissue at the same time. So genes that are expressed in brain tissue are different from, skin tissue from, versus gut tissue or something like that. So we really want to understand what genes are up or down in melanoma and then compare it with, benign forms, of moles, for example, and also within melanomas, aggressive melanomas versus non-aggressive melanomas. So RNA can, really uniquely give us those insights that would not be available from analysis of DNA alone.
Okay, fantastic. So fresh frozen is important because it preserves the RNA, and RNA is important because it gives us insight that we wouldn't otherwise have. Fantastic.
That's exactly right.
Okay, in simple form. But the other thing that I always want to be explained to myself and to our audience is that we're collecting primary tumor tissue. And so I want to take a minute and explain that when most of the people listening here have had either someone they love or themselves diagnosed with melanoma, and that was your primary tumor, more than likely, there's some cases where it's not, but the primary is the one that's staged 1 or 2. It's that first visit to the dermatologist generally when you're first told you have melanoma. If it metastasizes or spreads locally or in distance sites in your body, that tumor would be a metastasized tumor. We, for this tissue bank, are not interested in metastasized tumors. We're interested in primary. So can you explain to the audience why we're interested in primary tumors?
Yeah, I think principally for 2 reasons. One is because analyses that had been conducted before the tissue bank had started, and also even more recently, were really focused or limited to the metastases. And so since that was already done, we didn't want to recreate the wheel. But really, information on primary melanomas was really very scant. And so that was very important for us to do. And why? Because a lot of, when you're talking about a colon cancer or pancreatic cancer, those are several centimeter tumors, and so they're easier to come by, and a lot of them obviously get removed in hospitals. The difference with melanoma is that the primaries are a lot of times are biopsied and completely removed in the dermatologist's office, so that by the time the patient gets referred to a melanoma center, there's nothing there. So that's why these primaries were not collected. And so they're hard to come by, and that's why you really need a consortium. No individual site can collect enough of these for us to get a meaningful assessment of what's going on. So that's number one. The second, and I think even more important thing, is that, you know, the primary, in my view, and I think in view of other people in the field, has the genetic code for the entire tumor. So it's the primary tumor that has the genetic program, you know, and the genetic capabilities for what that melanoma can or cannot do, and will or will not do. And I think that the entire history of what's going to happen, you know, to that particular patient and their melanoma is embedded in that primary tumor. And we just have to have enough of these to look at, and we have to be smart enough to decipher, you know, what's going on. We have to be smart enough to figure that out. But we were precluded from doing that in the past because we just didn't have, you know, enough of these tissues. And that's really what this effort is trying to enable us to be able to do.
Got it. Okay. And one of the things that's been popping up in the questions and that I get asked all the time is a variation on the question of, can I donate my tissue and I got it taken out here, there, or somewhere else? And I can just answer that question for the number of people who've already asked it. And the answer is pretty much no, because of this fresh frozen issue and needing to get that information, that tissue frozen immediately, and it wouldn't have been. And then secondly, all the information, and we're going to come to that in a second and explain to our audience what we mean by that. The other thing I always say is the irony of all this is that people who are listening are going to want to help, right? Because we're going to get some great answers out of our tissue bank. And the irony is that it's probably people who don't yet know that they have melanoma who are going to be the most helpful for our tissue bank, because it's these 110 people who were just diagnosed in the last year or year and a half or so that we've been collecting, and the people who are going to be diagnosed in the next year or two that'll get to our 500 that we're trying to get to here to start. And those aren't people who are listening to our webinar right now. They have already been diagnosed, which is some irony, I guess.
Well, it's always hard to reach the exact people, you know, that you want to reach. But I think, you know, I tend to be an optimist, and I focus on the positive side of there is this effort, you know, that's ongoing, and it will result in this tissue bank that, you know, we all decided that we want, and we understand why it's important, and we will get there. Obviously, we wish we could, you know, have an infrastructure to get tissues from everywhere, you know, but that just logistically is not feasible, at least at this time.
Give us time. AIM is determined. I want to get to, yes, I want to get to your research, but I have two other questions that I think are important to ask. And that is, we're taking a number of things from the patients with their consent, and one of them is blood. Can you just give us an idea, sort of the same way you told us about RNA, why is patients' blood so important? And I know we're collecting in all these different tubes, and it has different purposes for research. What, for example, will you do with some of the blood you collect?
Yeah, I think, you know, blood in sort of the field of oncology as a whole, you know, the analysis of blood and what's sort of loosely termed liquid biopsy, you know, that this can provide insight, you know, at the patient as a whole, because if there are things that are circulating in the blood, you know, from the tumor, you know, then this would enable us to look at that. So I think this whole area of liquid biopsy and circulating tumor DNA is another way of looking at it, where people are looking for mutations of certain cancer-causing genes in the blood. This has exploded, you know, in all of oncology. And so, you know, we really want to be there at the time of the melanoma diagnosis to really see what's going on there. Beyond that, in addition to that, we're also not just poised to look at the tumor when we get blood, but also look at the immune system. So we're taking that blood, we're actually spinning part of it down, and then actually identifying the lymphocytes. These are the immune cells, and then we can actually interrogate, you know, at the time of the diagnosis, what was the immune component, you know, of the patient, and what was the level of immune surveillance? And as we understand now that immunotherapy plays such a big part of melanoma treatment and its more advanced stages, really understanding the immune component of the patient at the time of the diagnosis could also yield really wonderful insights in predicting, you know, what's going to happen in the future.
Okay, great. I had given you a list of questions, and I'm going to quickly jump ahead because I want you to tell the audience about your research. But I'll just end all these sort of how do we do it questions by saying that there's a patient medical record, which is anonymized. In other words, we don't know who the patient is with that information, connected to the tissue, connected to the blood, and connected to this epidemiological survey that asks things like, did you go into indoor tanning beds? Did you live in what part of the country? Do any of your family members have cancer? And all that information is put together so that we can start to see patterns, which I know you're going to talk about in a second. So tell us a little bit about your research and how it ties in with these tissues and blood and data that IMTBC is collecting.
So, a primary goal of my research is what we call biomarker research, which is really, trying to identify genes or proteins, that are involved in melanoma progression. And this is very broadly. Now, when we think about biomarkers, there's sort of three or actually four categories of biomarkers. One is what we call susceptibility markers. So is having a marker, a mutation or something like that, make us more susceptible to melanoma or not? So that's one category. And we're doing research on all of these areas. But the second one is a diagnostic marker. So, can we distinguish between a benign mole and a primary melanoma? This actually can be a very hard thing to do by classical pathology. And we really don't have accurate tests, that can help us guide those cases that might be ambiguous. So that is what we call a diagnostic marker. The third one is a prognostic marker. Can we, using the level of expression levels of various genes, say that, as I mentioned earlier, is this melanoma less aggressive than another one that is the exact same stage, exact same patient, age, gender, everything? So that's really a prognostic marker. Can we predict what's going to happen to that patient down the line, whether it's going to spread or not? And then the fourth one is what we call predictive marker, meaning that, again, if certain genes are up or down, it means that, this tumor and this patient more likely to benefit from a certain treatment, like immunotherapy or targeted therapy. But currently our focus really is on the diagnostic and the prognostic markers. And we've done a lot of work in that area with a very small number of fresh frozen tissues that we had collected in our own institution. And we got some really wonderful insights, but we understood that this is just, it's just the tip of the iceberg. And if we could really collect more tissues and have a consortium and have a really very viable bank, then, there's no end to not just the questions that we could get answered, but also the validity of the answers that we can get.
Okay, well, that's one of the questions I have. Will you help us understand why it's so important to have, I refer to it as a critical mass, 500 or more? I mean, we'd like to have a lot more, I know, but why is that important to have more than just a small number?
Because, really of the heterogeneity of melanoma, so melanoma looks different, in different parts of the body, in different ages of the patients that you present. I mean, there was a question about mucosal melanoma. So we have, but even within skin melanoma, mucosal melanoma, so there are different subtypes. So once you break down melanoma into its different clinical as well as molecular subtypes, so already some molecular subtypes of melanoma have been defined. So when you split it up, melanoma may be 4, 5, maybe even 10 different diseases, what we think of as just melanoma. So that's why when you look at these subsets, you need to have enough of each of them to be able to make a meaningful assessment of what's going on in that particular subtype. And then on top of that, from an outcome standpoint, most people are going to do very well, which is wonderful, but some patients are not. And so you need to have in your data set and in your tissue bank adequate numbers of patients, both who have never, in whom the melanoma has never spread, and enough where it has spread, so you can understand, if we want to develop that prognostication and that prediction, you need to have enough groups of both so that you can have an accurate prediction program developed.
Okay. Well, we're right at 4:29 and we're about to turn to 4:30. And I thank you so much for being with us. And I want to make sure to let everyone know that my email is in the chat. You can email me your question and I will share it with Dr. Kashani if I can't answer it myself. But very quickly, yes to the person who asked if a desmoplastic melanoma, any types that we can collect, we'd like to collect. And no, if your tissue was collected anywhere else, we cannot use it in the tissue bank because of this fresh freezing that must have happened pretty much moments after it was removed from your body, unfortunately. But that's probably the most common question I have on here. But still, if everyone, you're welcome to email me and questions that Dr. Kashani and I can answer. Thank you so much for joining us and letting our audience know why this tissue bank is so important for melanoma. We hope to get to 500 tissues within the next, I'm going to say year or two, but help me because we never knew that COVID was coming, did we? And, there's lots of things can get in the way, so that Dr. Kashani and his counterparts, his colleagues, can begin this research. We have to get to a critical mass in order to, as he says, assess correctly. That's why we have to keep collecting before we can do much with the research. We're starting right now. And we hope to have some things to report at the end of this year. So thank you for being with us, all of us in the webinar audience, and Dr. Kashani especially.
Thanks for having me.
Okay, signing off for everyone. Thanks a lot.